We're going to review some seizures now. We have talked about seizures, for example, in the neonatal period, and we stressed the fact that we really need to be cognizant in the neonate of subtle seizures. The other thing that we talked about with seizures in the neonate is, remember, hypoglycemia, and particularly with the George syndrome, hypocalcemia. A common one that we'll see and that you're going to get asked on the exam are febrile seizures. Again, look at the age. Typically around 9 months to 5 years of age, with the peak for febrile seizures being at around 14 to 18 months. Usually there is a family history of febrile seizures. It's not how high the temperature goes up, it's how quickly the temperature goes up. And sometimes actually the temperature can be coming down when they have the seizure. The febrile seizure can be classified as typical or atypical. The typical febrile seizure is a generalized seizure. It lasts less than 10 to 15 minutes. They really don't have much of a postictal stage, and they don't have any more seizures for at least a 24-hour period. That's what's called a simple, typical febrile seizure. There is no increased risk of developing a seizure disorder or epilepsy with this seizure. They really don't need much of a workup. They don't even need an EEG, and they don't need treatment except for fever control. Now, some patients are at increased risk to develop seizure disorder after having had febrile seizures, and these are the patients. Those patients that have a positive family history of seizure disorder, not febrile seizures, but of seizures. Patients that have had an atypical febrile seizure, meaning before 9 months of age, or a longer than 15 minutes, or a recurrent seizure within that same 24-hour period. These are all atypical febrile seizures. Patients that have abnormal neurodevelopment are at higher risk to develop seizure disorder or epilepsy. There's your definition of an atypical febrile seizure. You need to know that because they'll describe it, and then they'll ask you what the workup might be. If the patient has what's called typical febrile seizures, the workup is very minimal, if any. The main thing is to control the fever. They do not require to be on anticonvulsants. Now, if they start to have multiple seizures or atypical febrile seizures, then we recommend rectal diazepine for a greater than 5 minute seizure. Partial seizures can be simple. These would be focal seizures, which include most of the face or the neck, and they're very brief. Many of these will have an aura. They can actually feel it coming on, and there's no postictal period. You will not be given EEGs to interpret, but they may describe EEG findings. So look for spike and sharp waves, and the treatment will be anticonvulsants. The complex partial seizures will have some impaired consciousness at some point. Look for automatisms like lip smacking, somewhat like we discussed with the subtle seizures in the neonate. The EEG will show anterior temporal wave abnormalities. These patients will need an MRI as part of their workup, and you can see temporal lobe abnormalities on the MRI. And the treatment of choice is carbamazepine. So you may get a question where they describe a complex partial seizure. They'll say, what's the next step in the management of this patient? You want an MRI. The Rolandic seizures, or the benign Rolandic seizures, they have a characteristic EEG pattern with a normal background, but these spikes in the Rolandic area. These patients, usually by the time they're adolescents, they are cured of these seizures, and often there's a family history of them. This is a common one to get asked on the exam, is the absence seizure, also known as the petit mal seizure. These patients will have episodes of basically spacing out. They may be in school, and all of a sudden they get this blank stare on the face, and then they basically wake up again, and they might have some blinking. Then they might space out again and again, and you can see sometimes the teacher actually notices that, or sometimes the child will have declining school performance because if he's having them in school, he's missing half the class. It's more common in girls. They really don't have an aura, and they're not postictal. The characteristic EEG is known as the 3 per second spike and wave. It can sometimes be elicited by hyperventilation or a light stimulus, photic stimulation, so you can actually do it in the office. And these patients would need treatment with ethosuximide. Tonic-clonic seizures are these generalized discharges. They usually have an aura. They will have a loss of consciousness. The eyes will roll back in their heads, and they will have these tonic contractions. Then they'll start having clonic rhythmic contractions. Patients with these generalized seizures can actually bite their tongues. You can't swallow your tongue, but you can certainly bite it and bite your lip, and they can actually have loss of bladder function. They can be very sleepy or semi-comatose. This is the post-ictal phase, which lasts about up to 2 hours, and they can also have vomiting and headaches after the seizure. These patients, you're going to get an EEG, and the treatment is listed there. I don't think that they're going to get into too specifics about the medications. That's more for step 3. The myoclonic seizures are these very brief muscle contractions, and then they lose their body tone and fall forward. They might sometimes be called jackknife seizures, and there's a variety of kinds of the myoclonic seizures. There's one that's called benign myoclonus of infancy. In this type of seizure, it's not really a seizure. These babies occur when they're falling asleep. They may have these little jerking movements as they're falling asleep, but it's really not a seizure per se. The EEG is normal, and they outgrow this. This is a common one to get asked, is the infantile spasms. This babies will present, and it looks like a Moro response. So they will have these contractions of the trunk and of the neck, and they can then extend the extremities, and they can have multiple episodes in a day, hundreds of them at times. They look like the Moro or the startle response, except there's not a stimulus for it. Usually at around 4 to 8 months of age, and look for the characteristic EEG. They mentioned the word hips arrhythmia, means high and lofty. They're not going to show you an EEG to interpret, but they will mention the word. These patients they have increased corticotropin releasing factor, and that causes neuronal hyperexcitability, and the treatment is initially with adrenocorticotropin hormone, or ACTH. Some of these patients have, as they progress, the seizures basically tend to go away, the actual physical seizures, but many of these patients have severe developmental delays. We've already mentioned the neonatal seizures, so think of subtle seizures, the lip smacking, the chewing, maybe apnea. These occur in these babies. Always remember metabolic problems, remember infectious problems. Always check a blood sugar. Remember hypoxic ischemic encephalopathy can cause seizures in neonates. These are the babies that may have a low APGAR score. These seizures will usually present in the first 12 to 24 hours. Babies with particularly preterm babies that have intraventricular hemorrhages, those take a couple of days. That's why you get your ultrasound at around 2 to 3 days of life, an ultrasound of the head. Always remember infections such as meningitis in the neonate.